Welcome everyone to the Journal Club presentation. My name is PAV, an infection prevention and control professional. The selected journal article is Community-Acquired and Hospital-Acquired Bacterial Co-Infections in Patients Hospitalized with COVID-19 or Influenza. The Joanna Briggs Institute Critical Appraisal Tool for cohort studies has been used. This article was published in the Journal of Infectious Diseases and has been accessed over 2,400 times. The authors are from the Medical University of Vienna, Austria. They are from the Plastic and Reconstructive Surgery and Clinical Pharmacology. The authors have contributed to other articles on sepsis, chronic kidney disease, bloodstream infections, and drug-resistant bacteria. Although bacterial co-infections have been shown to be rather rare, the lack of distinguishing features between pneumonia of viral or bacterial origin may obscure their true prevalence. Results of previous studies on prevalence of community-acquired and hospital-acquired bacterial co-infections were highly inconsistent. This article describes the prevalence and microbiological spectrum of community-acquired and hospital-acquired bacterial co-infections in patients admitted to general ward with COVID-19 or influenza A or B. The aim of the study is to understand the prevalence and microbiological spectrum of community-acquired, which is identified within 48 hours of admission, and hospital-acquired, which is identified after 48 hours of admission, bacterial co-infections in patients admitted to general wards with COVID-19 or influenza A or B. It is also to understand the correlation between community-acquired and hospital-acquired bacterial co-infections in patients. Some of the challenges faced as infection control professionals. Respiratory infections, whether community or hospital, lead to prolonged hospitalization where bacterial and viral infections trigger host immune responses and alter microbial growth. Respiratory infections remain challenging for practitioners as they are airborne diseases and highly transmissible through aerosols, droplets, and airborne particles. Strengthening of infection prevention and control on infectious diseases are the responsibilities of practitioners ensuring health and safety of both healthcare workers and patients to prevent transmission within hospital and community. This article is relevant to my specialty as infection control professional. We are faced with complex challenges in managing hospital-acquired infections, commonly referred as HIEs, and community-acquired infections, commonly referred as SIEs, which are costly to manage. These infections severely impact patient outcomes, resulting in extended hospital stays with increased morbidity and mortality rates. Please take a look on the screen for some stats from WHO and Australian Institute of Health and Welfare and pay attention to the number of deaths and infection rates. In 2022-2023, there were possibly 548,000 preventable admissions in public hospitals and 178,000 in private hospitals. Summary of the study shows that the prevalence of bacterial co-infections was similar in hospitalized COVID-19 and influenza patients admitted to normal care wards. These findings contrast previous literature reporting that bacterial co-infections are less common in COVID-19 than influenza. Please take a moment to pause this video and review the research statistics which demonstrate the different HIEs. A study outlined that HIEs in adults admitted to public hospitals in Australia are 170,000, resulting in over 7,500 deaths annually. Highest number of deaths of 3,200 result from bloodstream infections, BSI. In 2022-2023, there were 1,668 cases of Staphylococcus aureus bloodstream infections, commonly referred as SABC or golden staph in public hospitals. There were 207 SABC cases in private hospitals. Antimicrobial resistant AMR infections such as ceftriaxone resistant BSI and vancomycin-resistant Enterococcus bacteremia remain costly and a burden on healthcare. Research gap depicts that prevalence of previous conducted studies were highly inconsistent. Previous systematic search identified lack of clarity, discrepancy between contamination or colonization and infection. There were inconsistent meaning of size and highs. Current guidelines on antimicrobial treatment and management of COVID-19 advise against the use of empiric antibiotic therapy in the absence of proven or suspected bacterial infection. WHO acknowledged that appropriate usage of antibiotics can reduce highs by 70%. The most frequent high is the hospital-acquired pneumonia, followed by surgical site infections and urinary tract infections. MRSA is not only challenging the healthcare, but is equally evolving in the community. The research question: is prevalence of bacterial co-infection in admitted patients with COVID-19 different from those admitted with influenza viral infection? The importance of the research question unravels the uncertainty and challenges for physicians in managing early antimicrobial therapy. It also assists to understand the prevalence of bacterial infections in both COVID-19 and influenza, and assist in instituting antibiotics at the early stage of infections to prevent deaths and severity of diseases from bacterial infections. The question assists to identify that the gap resulted in poor management on antimicrobial therapy. Methods used: a retrospective observational study with data extraction from hospital database was used. Pre-matching analysis set of 1,157 patients with COVID-19 and 180 patients with influenza. Propensity scoring was applied as COVID-19 cases were higher compared to influenza cases. Sample size was calculated on the ratio 2:1, that co-infections are more common in influenza than COVID. Match cohort of 550 patients, including 360 patients with COVID and 180 patients with influenza. The inclusion criteria were patients admitted with COVID-19 and influenza A or B, confirmed laboratory testing with PCR, and patients were admitted in general ward from February 2014 to December 2021, age 18 years or above, with antimicrobial testing for the groups. Patients admitted in intensive care unit and patients transferred from other facilities were excluded. As you can see from the image, a baseline characteristics of the overall and match study cohorts. Again, as you can see from the image, the study population flowchart. The method's outcomes. The primary outcome of this study were comparison of patients with COVID-19 and influenza in the propensity score match cohort. Secondary outcomes included comparison between patients with COVID-19 and influenza in the overall, that is the unmatched cohort, prevalence and distribution of identified bacterial pathogens, results from routine antimicrobial susceptibility testing according to the European Committee, time to bacterial co-infection, and 28-day all-cause mortality. The limitations were that the study was from February 2014, whereas COVID started in 2019. The study was tempered with covariates such as age, sex, length of hospital stay, and selective comorbidities such as diabetes, coronary artery disease, chronic heart failure, chronic kidney disease, and chronic obstructive pulmonary disease. To avoid study bias, positive respiratory or blood cultures with less than 48 hours and more than 48 hours for both focus groups were assessed. Antimicrobial testing was not done for all isolates. Gram-positive pathogens were not assessed. The study was only undertaken in Austria. The validity of the study identified that usage of empirical antibiotic therapy remains high. Overall, the paper revealed prevalence of bacterial co-infections was similar in hospitalized COVID-19 and influenza patients admitted to normal care wards. The strength of the study data from a single center study with a standardized care where the same team was responsible for management of the patients, robust methodology in using matched propensity score to serve as controls. Limitation of the study: the use of antibiotics might have influenced a rate of bacterial infection in the cohorts, which was not documented. Being a retrospective study might have contained a sizable missing data. Small sample size, particularly for a condition of high prevalence. In conclusion, despite the limitations, the paper has added a new information in the literature on similar prevalence of bacterial co-infections in both COVID-19 and influenza. Please take a moment to pause this video and review the summary of the results. To sum it up, bacterial co-infections were similar between COVID-19 and influenza matched cohorts. As you can see from the image, this is a brief interpretation of the result. Microbiology findings for psi, which is within 48 hours of admission, and highs, which is after 48 hours of admission, were identical in matched cohort. The frequency of psi's and highs between matched and unmatched groups were compared with the Fisher's exact test. Highest C-reactive protein and procalcitonin levels were used to assess correlation between bacterial co-infections and biochemical inflammatory response. As you can see, identification of bacterial pathogen in hours after hospital admission in both matched and overall cohort. Prior to cohort matching, baseline comorbidities was generally lower in the COVID-19 group than the influenza group. Similarly, frequency of microbiological sampling was lower in the COVID-19 patients than influenza patients. Propensity scoring led to a good balance of all covariates between the two groups. Percentage of antimicrobial resistance was higher in gram-negative isolates, causing highs than those isolates causing psi's. The trend was not observed for gram-positive pathogen. The 28 days all-cause mortality rate was considerably higher in both matched and unmatched cohort. In the overall COVID-19 group, community-acquired infections were significantly associated with an increased 28-day mortality. However, this association could not be observed in the propensity score matched cohort due to limited sample size. Overall, bacterial co-infections were similar between COVID-19 and influenza matched cohort. The article raised awareness with bacterial co-infections between community and hospital settings. As infection control professionals, surveillance is paramount to monitor for bacteremia or sepsis. Be vigilant with AMR and multi-drug resistant organisms. Management of antibiotic resistant infections such as C. diff and multi-drug resistant organisms such as carbapenem pose severe risk, especially to patients with comorbidities. Central line associated bloodstream infections with multi-drug resistant result in chronic management of bacteremia. Catheter-associated urinary tract infections result in pyelonephritis or sepsis. Be vigilant with AMR and MRSA. Wound or surgical site infections associated with MRSA are highly infectious and with vancomycin resistance result in chronic management. Again, as professionals, we need to understand the causative pathogens to raise awareness with appropriate usage of empirical antimicrobial therapy. We need to look at articles and evidence-based practice to be incorporated. Doctors ought to comply with appropriate antibiotic usage as C. diff remains the common cause of antibiotic-associated diarrhea. C. diff are enteric diseases where the microorganisms are highly transmissible for the oral fecal route and remain one of the biggest threats for both healthcare and community settings. ICPs must strengthen the need for enteric precautions. In conclusion, this article depicts how highs and psi's can interact to intensify diseases and prolong hospitalization with significant morbidity and mortality rates. By highlighting the challenges associated with AMR, this research helps ICPs to improve practices and respond more effectively to infectious diseases in both hospital and community settings. Implement strict measures including airborne and droplet precautions and enhance cleaning and isolation protocols to mitigate transmission. ICPs must remain vigilant and implement rigorous IPAC strategies with surveillance and reporting, which is paramount. Provide training to healthcare workers in managing infectious diseases and ensure safety and compliance, such as rigid adherence to safety practices, proper handling of shops to prevent needle stick injuries. ICPs to ensure correct use of PPEs and to continuously adapt to strategies addressing various pathogens and mode of transmission. Thank you very much for listening to my presentation. Looking forward for your commentaries on the journal article. Please find the references used and some more references. The references used.